Welcome back, ladies and gentlemen. We've now come to the closing plenary session, The Future of Precision Public Health in Asia, kindly brought to you by Platinum sponsor, Illumina. This session will discuss the opportunities and challenges in unlocking the full potential of precision public health in Asia. It will explore collaboration, support, and expertise needed to develop better, more effective, personalized public health interventions for the greatest impact. Moderating this session is Associate Professor Jeremy Lim, Director of the Leadership Institute for Global Health Transformation at NUS Swee School of Public Health. Jeremy is also co-founder and Chief Executive Officer of 𝗪𝗲, the first dedicated gut microbiome full-service company in Southeast Asia. Trained in surgery and public health, Jeremy has a special interest in the ways that technology can increase health equity and access to care. He advises several health technology companies and programs, both in the region and globally. He also advises and serves on boards of various charities and social enterprises, including 𝗙𝗃𝗃, 𝗣𝗵𝗃𝗀𝗃 Hospice, and the Special Needs Trust Company. Jeremy has worked in executive roles in both public and private sectors, including as a senior official in the Singapore Ministry of Health and as a founding partner of the 𝗙𝗃𝗃𝗰𝗔's Health and Life Sciences practice in the Asia-Pacific region. Jeremy, please.
Thank you very much, Kiesha, and a very good morning to all of you here in Asia. Thank you for staying with us through to the last plenary, which I assure you will be a very exciting one. I have looked at Ben's slides and certainly looking forward to his presentation. What we will be discussing today will be the future of precision public health right here in Asia, bearing in mind that Asia is really a geographic construct, and Asia spans the entire gamut from very, very poorly resourced countries to much more affluent ones with challenges ranging from malnutrition, both under as well as over, the so-called double scourge of both the chronic as well as the infectious diseases. So what can precision public health do for us here in the Asia Pacific? But before we jump into the panel discussion, I would like to introduce Professor Benjamin Howden, who is the Director of the Microbiological Diagnostic Unit Public Health Laboratory and Medical Director of the Doherty Applied Microbial Genomics at the Doherty Institute. Ben joined us in some closed-door sessions over the last 2 days, and extremely eloquent and really knowledgeable speaker. So without further ado, can I hand the time to Ben? Ben, over to you, please. Thank you.
Thanks very much, Jeremy, and really thank you for the invitation to speak at this really interesting and important meeting, and thank you and the organisers for the invitation. So hopefully you can see my slides. I can't see, oh, there we go. So my talk will be focused on as an Australian perspective and focused on pathogen genomics. Obviously the topic we're talking about, precision public health, is much broader than just pathogen genomics. But in Australia, I would say we've made quite a bit of progress in bringing this technology to the public health interface. And so I'll just tell a bit of a story about how that's happened and some of the lessons we've learned. So, and then I think that will be a useful platform to have a discussion around the broader use of precision public health and genomic technologies. So how did we get here? A little bit about the Australian landscape and the governance structures, because I think that is key. One slide on the applications of public health pathogen genomics for COVID-19, and then a little bit about technical solutions, the AusTracker National Genomics platform that we're using in Australia and how that has helped propel the technology forward, and then the future AusPathogen program. So the Australian landscape is important to understand when thinking about implementing new technologies. So we're a federated country with 8 states and territories with quite diverse infectious disease challenges due to very big differences in climate and other issues around how the population lives. There's really a shared responsibility for public health so that the states and territories deliver the service, but there is coordination at the Commonwealth level. And decision-making is made by committees, so that represented by the states and coordinated by the Commonwealth. And each state has their own public health laboratory and their own public health unit, but the size and breadth of and scope of activities varies between the size of the jurisdictions. So this is the timeline of what's happened with pathogen genomics for public health in Australia. And I'll briefly go through this just to highlight, that it's been a 5 to 7 year program to deliver this technology at the public health interface and inform public health decision making. I really started in academia, which is not surprising, in the early 2000s. And then by the late 2000s, some of the clinical and public health labs were using genomic technology to answer small research questions around the spread of antimicrobial resistance in hospitals, for example. And after that, there was really a push in the mid-2010s to start to look at the use of this technology in public health laboratories that serviced public health units around the country. And there was a couple of key jurisdictions that took this lead. And what this did was inform a really strong evidence for the utility of this technology at the state and national level, and led to, similar to what we're doing here, the first internationally attended symposium on the use of genomics for public health in Australia, which really propelled the momentum forward in terms of garnering interest in the value and excitement of the technology. This led to the establishment of the Communicable Diseases Genomics Network, which is a network of laboratories who are working at the public health interface. So it's not a research network, it's a network of the public health labs that are trying to deploy this technology, ultimately leading to some first nationally integrated projects around Listeria and Salmonella, and then more recently informing government around a national microbial genomics framework and the establishment of a platform called AusTracker, which is based on some work in the US around the technology of Genome Tracker that has been endorsed now at the highest levels as the public health genomic tool for Australia. The governance is important, and I think if we're implementing anything into public health activity, clearly understanding the governance structures are key. And this is just to highlight that there is a standing committee, the Australian Health Protection Principle Committee, that oversees health in Australia, and that there are two key pillars. One is around infectious disease epidemiology, CDNA, and the other one is around a network of laboratories, the PHLN. And what we did was establish this Communicable Diseases Genomics Network to sit under and report to the Public Health Lab Network so that we could formally report up to the key government agencies making decisions around investment and strategic policy decisions. So the CDGN, that we've called it, every public health lab in the country was invited to be a member of this this group, which was started from my laboratory at the University of Melbourne at the Doherty Institute, and really was a voluntary collaborative process to start with, and then ultimately became a formal expert reference group under the Public Health Laboratory Network. And the objectives were really to work at the implementation interface to establish a unified public health microbial genomics network to advise laboratory and public health labs, governments and policymakers, and to really standardize the use of whole genome sequencing methods and also metagenomic platforms. And the key thing was to develop policies around rapid sharing of data, because each jurisdiction, each of the 8 jurisdictions really owns their own public health data in Australia, and finding processes to allow rapid sharing has been a key objective of this group. The group is underpinned by pathogen genomics enabled public health labs, and this means in Australia that these labs are accredited to international standards to generate and analyse genome sequence data. They're supervised by RCPA accredited pathologists. So the Royal College of Pathologists of Australasia has developed a pathogen genomics module for accreditation of pathologists to oversee these laboratories, and really trying to undertake best practice methods within these laboratories, both within wet lab processes, the bioinformatics, and also the genomic epidemiology, which is taking the bioinformatic results and linking them to public health unit epidemiological data. This informed, a lot of the work of this CDGN group informed the National Microbial Genomics Framework, and so the public health labs were a key driver of this framework that was ultimately released a couple of years ago. And you can see the key strategic priorities there: national standardised approach, technology and governance, integration, and a key issue around access and workforce, so equity of access to the technology and workforce, and also some plans around financing. And you can see some of the key challenges which have been discussed over the last few days around consistency in protocols and reporting. And this has become incredibly important so that federal agencies understand the information they're receiving from each of these public health labs because they're being reported in a consistent and reproducible way. And any uncertainty around that really leads to loss of confidence of the use of the technology. Data sharing has been key, and we're still working on that, but we've made a lot of progress. And I think the other thing is about how you take this technology, which is new and exciting and different, and integrate it into public health lab structures that have been embedded and working in a similar way for a long time. And we're still doing a lot of work to understand how best to do that. So here's a brief summary of the National Public Health Genomics Program. So we now have nationally integrated data across a number of key pathogens. No doubt it's been driven forward very strongly by the COVID-19 pandemic. And we have nationally integrated COVID-19 data. But there's been a number of other key pathogens, particularly in the foodborne diseases space, because the integration of data from humans, non-humans, and across jurisdictional borders is very important for foodborne disease surveillance. Statewide programs are still focused on a number of other pathogens, which you can see listed there, including antimicrobial resistance as a key, but there's a plan to try and bring this into a more nationally coordinated approach in future. So how do we use COVID-19 as an example of what is possible? And there's no doubt that we have seen COVID-19. We've had our Prime Minister and our ministers and chief ministers of our jurisdictions talking about genomic data in the media frequently because of the importance of this data to understanding the epidemiology and the sources of disease in Australia, which has had a relatively low burden of COVID-19. And so the data is being used to support local transmission investigations and outbreak identifications, frequently used to identify the source of new cases, for example, from hotel quarantine outbreaks, and to identify transmissions between residents and staff in hotel quarantines, but also in healthcare facilities. And then more recently, we have got to the stage now where we have nationally integrated data where all jurisdictions are in real time uploading their COVID-19 data to AusTracker, which I'll talk about in a minute, which is a protected closed system for integration of genomic data in real time so that we can actually get a national snapshot of what is happening on a day-to-day basis. And this has been driven, and many of you will be aware of this issue of variants of concern and emerging variants of COVID-19 that are causing threats to outbreaks and vaccination strategies. And so there's been a very strong desire from policymakers and governments to understand these variants and whether they're present in populations. And this has really facilitated and streamlined the approach of getting approvals to do this type of integrated data analysis at the national level. So the AusTracker platform, talking about, we need technical solutions as well as policy and funding and governance solutions. So the technical solution for us in Australia at this stage is a platform that's been developed through the University of Melbourne by a couple of the lead bioinformaticians here. And the purpose of it is to provide consistent and standardized genomic sequence analysis and reporting, and to allow real-time genomic analysis and surveillance. And the reason this is important in Australia is that 2 or 3 of the jurisdictions have quite a lot of pathogen genomic capacity at the public health level. A number of others don't have that, but by providing this freely available platform that's working to ISO standards, those other laboratories have had the confidence to start to deploy their sequence data into this platform and to report back to their public health agencies based on this data. And so this has been a very powerful step forward for Australia. At the moment, it's central and secure, and there's no doubt, I think all of the people we work with in our network are very pro open data sharing, but there's no doubt also that in the public health space, there's a lot of concern about ensuring consistent messaging and making sure that data is protected until an appropriate time that it should be shared. And so that's how this platform works. So the utility of this platform for COVID-19, it's been accessible to all laboratories in the country, also with some international context through freely available data. And it's now got to the point of being reported through our surveillance reports in a publication once a month. And it has particularly assisted jurisdictions with limited capacity and ensured consistency. And as I said, allowed real-time monitoring of key threats that are reported to national committees, government, and right up to the Prime Minister's office. So where to next in Australia? So we've learned a lot over the last few years and propelled forward very strongly by the COVID-19 pandemic. But the next step is really the broader deployment of this integrated pathogen genomics program for infectious diseases more broadly at the national level. And you know, we're playing that balancing act of enhanced surveillance and public health service delivery and research. But we do have this new national program which has been funded by the Medical Research Future Fund in Australia, which is a research initiative, but really working at the translational end, really to go to the next level with this program, really to optimise national genomics-based surveillance and investigation of infectious diseases through AUSTRACA, and to implement national genomics-informed responses to these threats. And a key part of this, and this has been discussed in the conference, is around evaluating the utility and cost effectiveness or the cost benefit of using this type of platform for public health. And these are we're really moving into that stage of evaluation and implementation science. And these are some of the key outcomes that we hope to achieve during the 4-year programs, really improving equitable access to pathogen genomics, establishing the ideal models for the National Public Health Genomics Program. We've certainly made some progress there, but there's a lot more to learn, and really strengthening capacity across the whole country. And really informing future investment in public health genomics. So by assessing the impact and evaluating some of the cost benefits, we can inform future investments. And really the other thing which I haven't talked about much yet is the trained workforce. And so there's a real limitation on workforce capacity in bioinformatics at the public health interface. There's a lot of bioinformatics in the research space. There's not a lot who work in laboratories and are comfortable working on international ISO standard bioinformatic tools that are highly reproducible, and you can inform patient or public health decision making based on them. For us in the pathogen genomic space, the genomic epidemiologists are key, but we also need laboratory supervisors who are trained to supervise pathogen genomic laboratories, and there's only a small number of them at the moment. So just to summarise then, this is the final slide. The National Public Health Genomics Program is really, in Australia at this stage, been driven by public health labs that are working at the intersect of research and service delivery. The formation of a collaborative national network is very important in driving forward our program in Australia. And what it did was lead to consistency in forming state and national policies and advice around the use of the technology. The key issues remain governance and ensuring that everything we do is appropriately governed at the national and state level. The data sharing is developing, but still needs a lot more work. I think standardisation and accreditation are key if we're going to be using these tools to make public health decisions or inform patient treatments, and equity of access and ongoing funding are still very important issues. So that's all I would like to say. Hopefully that's given a good overview of where we've got to in the public health genomics space. I don't have an acknowledgement slide because there's actually a huge number of people from around the country involved in this work, and particularly the public health labs who have been working collaboratively for a number of years in this space, and also the funding agencies at the state and Commonwealth level. Thank you.
Yeah, and thank you very much, Ben. That's a very wonderfully concise but yet comprehensive overview of how the program has evolved. If I can summarize the thoughts, because really, Ben, as I listen to you, it's also striking me that this is almost a template for how to develop precision public health really across countries and across the region. It almost always starts with like-minded, passionate individuals, be they from academia or from industry. Then you pick your battles. There's a very single-minded focus to prioritize certain pathogens or certain disease states, and with experience this then broadens out to more, and this then almost then quite ironically coalesces back into a national program. And with a national program, then the structures around governance, around workforce preparation, the development of the networks, data sharing standards, and very importantly engagement of the public. These all really coalesce together through the national program. And with a national program, you then start to develop linkages regionally as well as globally. And I see this as really a roadmap for all of us in really precision public health. So before we go into the panel discussion, I would like to introduce my good friend Pairoj, right, who is joining us from the Thai Health Promotion Foundation, where he's the director of the Healthy Lifestyle Promotion section. And we'll ask Pairoj to share some thoughts on his experience around precision public health in his space before we open up to the panel discussion. And can I invite participants to keep the questions and the comments flowing? There are a few that have come in. This is our closing session, so it's your last opportunity to ask these really distinguished speakers any questions you may want. And Pairoj, over to you. Thank you.
Thank you very much, and good morning, everyone. It's a good example that I had heard from Ben about the pathogen genome program, and we can use this case to look more in detail and share with the other issues that deal with precision public health. To my experts, I work in Thai Health Promotion Foundations on the health promotions, and I am focusing on the lifestyle. So you can imagining that if you change the pathogen into the lifestyle, running, eating, and smoking or alcohol drinking as a pathogen, you can see the same and in different approach from the pathogen itself. Ben has draw your imaginary that how to deal with is two parts. First part is to deal with the issue-based issue, specific issue like a pathogen, like a lifestyle. We can deal it by the disciplinary itself or by the expertise itself. But for the broader view, we manage around about the political, about the national program that need the investment, that needs government data sharing. So when we look for the health promotion field or disease prevention that require the same, we need the strong evidence from the laboratory, from the surveillance system, from the data survey, and this will lead to the policy level. We can enact the law, enact the regulation that's like a frame for decide the healthy lifestyle. And if we can engage more for the people or the population itself, that can be the effect population, or they can be the active population that can be a part of the solution, so it is better. So in conclusion, I think that pathogen genomics is a good example, and we can learn from this system, for this experience, to work more in the other issue like health promotion or disease prevention. Over to you, Jeremy. Thank you.
Yeah. Thank you very much, Pairoj. And I cannot overemphasize the point that Pairoj made, that we could replace pathogen genomics with exercise, with diet, and that's really a template and a very apt exemplar of how we can develop and scale up programs. We have a couple of questions coming in. Perhaps can I start with a broad question first before we go into the specifics? And there's a question here around if I can paraphrase it, but the questioner is frustrated. It's really, we have the technology, we have the skills, we have the need. Why isn't it happening? What are we doing wrong, right? When the world so clearly needs us to get our act together, all of us as public health practitioners, all of us as people who care passionately about making the world better, why isn't it happening, and how can we collaborate better and more openly to implement all the exciting things we have discussed the last 3 days? Maybe Andrew, do you want to take the first stab at it, and then we can go around? Yeah, and guys, it's not a monologue. Please feel free. All of us are on the screen. Feel free to interrupt, to interject, and I suspect that it's Friday. After this, if it gets too tense, we'll all adjourn to have a drink. So please, Andrew, over to you.
Thank you, Jeremy, and Ben. That was an excellent talk. I concur with this question in many ways, like where this frustration is coming from. So where we have the technology and skills, where there is a need, why is it that we're not able to push this together? I think in some respect, you know, sitting at the Gates Foundation, we work in many different ways, and I myself have learned that, you know, there's a traditional global development community pathway, which often leads from large multilateral organizations down to support with the public health officials and ministries of health, ministries of ICT, and then work down toward those end beneficiaries. And I think that typically I would call is a push model, right? Where there is this recognition that technologies could be useful, but it takes quite a long time to filter through all of those levels of components to be vetted, to demonstrate utility, to have funding sources, especially sustainable funding sources. And we have been exploring a alternative model, which here I will just call the pull model, which may represent actually exactly what's happening here. And maybe that doesn't fit exactly with the genomics space, but perhaps on health promotion could be a good example, where the citizens themselves, the end beneficiaries, recognize that there is this opportunity to do something differently. And rather than self-assembling and trying to develop things in this way, we recognize that enablement of the groups that already exist within a country, the ability to bring entrepreneurs together to help to catalyze some of these technologies, effectively, in some ways, reflecting back this workforce issue at the very highest end. So things like bioinformaticians or ISO certified technicians that Ben mentioned in the talk, but try to see how is it that you could build a more robust system within countries to support for oneself. And so in combination, we are finding that there are opportunities now at the highest levels to take the potentially most complex technologies, say to put genome sequencing capacity and cloud compute infrastructure in places that may not have access today, while also recognizing that a lot of the tools that we see that could really bring forward this concept around precision public health really could begin in the communities, in the lower level health systems, where people are already getting care, but ensuring that the data are flowing in a way that the decisions can still be made centrally for the population as a whole. And I think that COVID, as we talked about earlier on day one, COVID has just rendered open all of the schisms that exist, all of the inequities across, you know, within countries, across countries. And so now as we look forward, and hopefully it's not too far into the future that we can actually move beyond the current status of the pandemic, the recognition that, and this energy that this question that underlies this question, I think it will be contingent upon all of us to find ways to come together, to share the best ways that we approach these questions, and find opportunities to bring forward some of these technologies. It's not, I'm not you know, Pollyanna here. I understand it'll be quite difficult, but I do think that that one of the major concepts that we have seen already emerging, particularly within the context of Asia, is that entrepreneurs and citizens do have the capacity to make differences within their own communities. It's just a matter of finding the best way to catalyze those changes for the betterment of everyone.
Yeah, and if I can challenge this a little bit, it seems very nice and cozy that there's a push model and there's a pull model, but a word that is rife in so many other industries is this word disruption. What do you think of the disruption model? I mean, no, I'm sure Uber didn't ask for permission before it's set up, neither did Airbnb, and while we in traditional health and public health are a little allergic to maxims like move fast and break things, because people die when we move fast and break things, but at the same time, I think that our slowness in really adapting some of these technologies that have become mainstream in so many other sectors are also costing lives. Let's not harbor any illusions that our sitting on our asses and not doing anything is not costing people's lives as well as livelihoods. And I would not be surprised if there are garages out there that are filled with young deviants who are getting ready to disrupt all of us old guys in traditional public health. And what do you guys see? Is it a good or a bad thing if we get disrupted? Andrew, Ben, Pairoj, who wants to take this?
I'll jump in on that.
Okay.
so I sit on an innovation team where our entire motto is to disrupt, but it is still a recognition that it is quite difficult to bring that disruption and ensure that it's going to be sustainable without that core customer base, if you will, right? So Uber managed to build entirely new model of linking both supply and demand. In this context with healthcare, the basic supply is not matching to the demand, largely because of the regulations that we have. I would not argue that we should work in healthcare outside of the regulations. That would be kind of difficult to imagine. But I do think that we have opportunities to take that type of energy and absolutely apply it to the problems that are on the ground. And this is, in fact, the entrepreneurial spirit that I was mentioning. We have found a lot of telehealth startups, many groups looking at things like e-pharmacy or building alliances among traditional brick and mortar, but disrupting the upstream, right? How do we get better supply chain? How can we ensure that there's not going to be falsified drugs? How can we provide patients back some record of their visit that makes it actionable? Those things are looking direct to the consumer, but ultimately the question becomes, how does that translate into public health? And one of the core elements, just as Ben was mentioning, relates back to how the data standards exist, and is there a mandate to ensure that those data flow appropriately? Yeah. I would argue that those have to be not just standardized and mandated, but also that there's a known action that can be taken, right? So just like with pathogen surveillance, there were actions taken in the global community using some of the genomic sequences. Yeah. We're still left with questions about a lot of these data collected from people, and certainly after our first session a few days back, I got a lot of questions about that afterward. And so I sense that these are the new areas that the disruption will be to ensure that the people, the beneficiaries, are at the center, but that is going to be going against the status quo. Over.
Yeah, thanks, Andrew. And Ben, have there been cases in Australia where people have tried to disrupt? Because what I'm hearing from Andrew is really that the government or the kind of traditional incumbent's role is to almost build the roads, put in the lampposts and the rules of the road, but let the innovators build the cars. So really stay within the guardrails. What has the experience been in Australia?
Yeah, this is, this may not sound accurate to you, but, I feel like by establishing our national network, we were disrupting a model, which is implies, I'm sorry, okay. It depends how extreme you're talking about with the disruption.
No, you are officially sanctioned disruption.
Getting the labs to talk to each other each week and agree on a consistent approach to this was a disruption to the current model. So, but it still fitted, within a framework, and we weren't, I think it's tricky for us, and the example for me is someone who works at the public health interface, and I'm funded through the public health agency and the government, and so pretty tight constraints on the way that we can move and change and shift. Yeah. And we really need the support of our funding agencies and our governments to make change. And I feel like, it's been a reasonably somewhat slow process, but it has also been embedded in the structures that allow it to be sustained and approved. And we have ultimately been able to inform very high levels decision makers around the value of what's happening, but it hasn't been disruptive in the sense that it hasn't been quick. But I do think the other thing that's happening, and we haven't talked about this too much, is that the individuals that we're collecting data from, or the sequences of a pathogen, come from an individual, and increasingly those individuals are going to be interested in the implications of that data. And so disruption is going to come, and it started for us around legal ramifications of the data that we generate, and being able to inform the source of someone's disease from another person or another community is now coming to the fore. And so I think individuals will become, once they become more literate in this idea of precision health and genomics, should be forcing that agenda a bit more at the senior level. I'd say our governments are going to be very slow to do things if it's just us as agencies that are funded by them pushing an agenda that they'll only respond to ultimately if they're really forced to. But I think having a very literate population that understands the value and possibly the risks of this data, I think is going to be somewhat of a disruptive force.
So, Ben, what you're really describing is a grassroots innovation, and the thesis of the case is that as the general public or the population get more literate and more familiar, and if governments start to legislate to empower individuals to own their own health data and to give the right to third parties to access this data, then we have a more fertile milieu for disruption with all its positive as well as negative connotations. Pairoj, do you see that in Thailand? I mean, amongst the health technology companies and the startups, who are the naughty ones that seem to be not in the black or white, but in the gray area, and whether it's in mental health or any other area?
Yes. For Thailand now, we are talking a lot about the Personal Data Protection Act, that is normal for other countries, but it's a new one in Thailand now. This will interrupt our works on the data sharing, but we are now learning from yours and your country that how to deal with and shaping our action in real time. To our talks, may I focusing on the digital disruption. This word has been discussed in many platforms, many conferences, including Thailand. But we learned that we face the same problem in the implementation in the local. We have talked a lot, but cannot implement at all because and I saw some opportunity that we can work together. Particularly in Asia. In Asia, we face the same health problem, both infection disease or non-communicable disease. The example is like tuberculosis. Pulmonary tuberculosis is a 1,000-year disease that we have faced, and we cannot solve it. However, the good news is that the new technology, the new diagnosis, and the new treatment has emerged and developed. So in Thailand, we adopt this technology, and we know that if we use the artificial intelligence to check X-ray that can detect very fast and accurate, and use the gene express to explore the genome of the microbial, then we can know the better and put the right drug. So we can apply this to the other disease in our regions to eliminate some old disease make our health not good enough when comparing to the other regions. For the second point, that is the technology transfer. COVID is an example. You can transfer the technology from the high-income country to the low-income country, and or use the each country be a platform for testing, working together, and share the experience, or scaling up at the each characteristic of the countries. So that needs the investment or the financing. I know that many countries face with the budget constraint, but if you can learn from the other country and learn by yourself, you can shaping, adopt, and will be decrease the cost. So financing limitation will be solved. As in Thailand now, we integrate many platforms together, so we can decrease the cost to many intervention, particularly in the digital. And the last one is the capacity building. I think this is a very important one. We cannot talk only the number, but for the capacity itself, availability to test, to work, we can produce the one more powerful person to do very strong works. So please focus on the capacity of the workforce. Thank you very much.
And thank you, Pairoj. That's a really good segue into a question that's specific to Ben, but I guess it applies to all of us who are more privileged to be in the affluent countries. And the question to Ben is, how can affluent countries like Australia use its technology and expertise to help other countries in Asia?
Thank you for the question. I think, and we've thought about this a lot lately, because there's actually been a lot of requests to assist and provide guidance on the use of genomics for COVID-19, which is clearly the clear and present issue for many of us in the region. And so I think it's a mixed model of sort of partnerships around demonstrating utility, providing options for rapid sort of referral and support for the technology, but at the same time working out how to build relationships that can lead to capacity building and regional deployment of the technology. So it's complex. I mean, in many of the countries and laboratories we're talking to, they are not completely on board with even real-time PCR, let alone the use of genomics. Nonetheless, they're making a leap of faith to wanting to understand the genomic results to inform public health decisions in regional countries. And so I think we're now just at that really acute stage of working out how we can support that in a way. And I think it needs to be a network support, because it can't be one laboratory, and it needs to be partnerships between laboratories with capacity and interest in providing that regional support. And a tiered response that might be just providing a service in the short term that allows those countries to access data that they need, or other models which might be a hybrid model of testing and deploying technologies in country, but with regional support. And I think the workforce is important here. So the bioinformatics and the genomic epidemiology of COVID is not straightforward. So you can't deploy the technology in one of our regional low and middle income countries and then expect them to analyze and report on that data for public health action at the national level. That's a challenging thing to do. So providing that technical support around ensuring the data analysis is correct, the report writing is accurate, and that the information that's passed back to public health agencies is going to be appropriate, I think is really, there's quite a lot of work to do to make that happen. And I would suggest that the network model, as we've done in Australia, it's taken a long time to get there, but in the region would be a good way to do that.
And Ben, if I can challenge you a little bit more, somewhat on your philosophical grounds, why should Australia even want to do this? The WHO has constantly emphasized in this COVID pandemic that no country is safe until all countries are safe. But the rich world then monopolizes vaccines for itself many times over, while leaving the poorer countries to flounder. So philosophically, why should Australia even bother?
Well, maybe you're asking the wrong person, because philosophically, I have a strong belief in the need to do that for, I'm purely the grounds of being a, appropriate global citizen, but I'm not sure that everyone has got that same feeling, and obviously that's a key challenge. I think, the Australian government does have a Department of Foreign Affairs and Trade that is strongly supporting the region in the COVID response. So there is a government level investment in trying to provide that support. And that's probably a two-tiered response. One, which is, yes, we want to support our neighbours and our friends. Two, we want to, by supporting our neighbours and our friends, we protect our own country in terms of the regional threats. And that would be for COVID-19 or antimicrobial resistance or many infectious diseases threats that Australia may face.
Yeah.
So I think it's a combination of that government level policy and support, which needs to be in place and is to some extent, but it is also probably still quite dependent on individuals with a strong belief and a desire to do that sort of work as well.
Okay.
So it's a combination of the two at the moment.
Okay, great. Yeah, and can I switch gears to Andrew? And Andrew, and I will be very candid that your presence in this conference and your speaking in the plenary and in this closing discussion on precision public health in Asia has led a number of people to ask me private chat group and please do use the conference Q&A function to ask questions and not send to me directly WhatsApp questions. But Andrew, the question for you is, what are the Bill and Melinda Gates really Foundation plans for digital health here in Asia, since that is your specific mandate? And if I can be presumptuous and ask a question, because personally, I feel that my own country, Singapore, can and should do much more in the space of global health. What would you say to the role of the Bill and Melinda Gates Foundation in digital health here in Asia? And I won't get you into any trouble, but please do share some thoughts on what you think Singapore can and should do. You have come to visit us many times, and we consider you a dear friend, so we would be very grateful for any gentle criticism. Andrew?
Well, I don't know about criticism. There's a lot we can do together, and I'm quite keen to learn from all that Singapore has already done in the region. But with respect to the foundation, the majority of the work that we do in the world, in the global south, is focused on sub-Saharan Africa and in South Asia, with primarily within India, but also in Pakistan and in Bangladesh. We do have a regional office in Beijing, and that was work that was done primarily to focus on tuberculosis in China many years ago. And there's right now a recognition that within Southeast Asia, the malaria focus that the foundation has certainly looks within the Mekong Delta, tries to understand ways that there are artemisinin resistant strains. However, the majority of the work toward malaria elimination is still focused within sub-Saharan Africa. From a digital standpoint, our remit has been much broader. And so while we still try to find exemplar programs where we can bring technologies into the same regions, the co-chairs and the leadership of the foundation have allowed us a greater latitude to find ways that digital tools are already being used, ideally in countries, say in middle-income countries with reasonable GDP, so that we can begin to see what the future might hold. And the opportunities that I see, in fact, are related to every time I come to Singapore and I feel like I, step into the future, especially leaving a decrepit, airport here in the US and 18 hours later showing up and, the glistening city. And, but that in reality, I think is true across the board. This is not only Singapore. This is in fact many cities across the region in Southeast Asia. There is the young population have become digital natives. There is a adoption, not at the bottom of the pyramid, but certainly within the burgeoning middle class, even in those countries that have potentially lower resources. And we have recognized that a health system that takes advantage of those infrastructural components, that allows lower barriers to access for individuals directly, that uses data in ways that are more efficient, could become the norm across the world. And sitting within the US and having practiced in the US health system, I would say this is not exactly one of those circumstances where we'd want to take from a high income country and you know, transport to a low income country. There's very little within the US health system that makes sense to borrow or to bring forward. Now, individual technologies do make sense, but what I see is nothing short of an opportunity to completely leapfrog, as we have with so many other technologies in the world. And when it comes to health, and truly like removing the digital component, just say health that is related to digital tools, like completely you know, infused across the entire fabric, we have very, very novel opportunities to see differences in the workforce. So the workforce problem is a major problem across the world, primarily, I mean, acutely a problem in low resource settings, but there are also many opportunities where we may not necessarily need to train up, you know, to highest, say, doctorate level degrees for people to still be able to deliver care, as long as there may be a tool that can help to augment that health worker. We have thought about ways to take advantage of, well, as in Singapore, the social fabric of communities looking out for one another, of having access to community centers and to polyclinics. How does that then translate into elevating the care, elevating the agency for the individual within the community to choose to do things or to have access to knowledge for their own care? I think something that Pairoj also thinks about deeply within the context in Thailand. And these are the types of opportunities that we see across Asia. And then specifically for precision public health, it comes back to if we can build a paradigm in the communities with members benefiting, how then do those data come back to broaden the applications? And so I think from the foundation standpoint, we are very, very keen to learn, also to help to influence ways that these types of technologies get catalyzed, but ideally done so in a way that is sustainable and not definitely not in the old context of the push model that I described earlier, where those really relate to an endpoint that have in a more subversive way, people talk about this addiction to philanthropy, right? That's the thing that we want to avoid, absolutely. Digital should not, I mean, maybe other tools and other types of things still require philanthropy. You know, ivermectin campaigns for onchocerciasis, as an example. Certainly, it's going to be very difficult for the global development community to pay for those drugs. We must relate to philanthropy to ensure that they are still used in mass drug administrations. Digital tools have broad applicability, rich and poor world alike. And so for these reasons, we want to ensure that any product that is used could be used anywhere, and that there's actually, again, perhaps subversive, but there are opportunities to change the model completely in high-income countries by first learning in the low-income countries. And then that becomes a sustainable model where people pay what they can.
Yep. And Andrew, can I tease out the point you made about diffusion of technology from high-income countries? And I'm mindful of what 𝗣𝗿𝗋𝗶𝗀 mentioned on the first day, that a lot of technologies start off very expensive, but as we scale up, as we get better at really delivering the same outcome in much cheaper ways, it then becomes affordable in the global south. What do you see as the role of foundations such as the Bill and Melinda Gates Foundation in making sure that this flow happens and it's accelerated, and we move away from this phenomenon of global pricing that some pharmaceutical companies practice?
Yes, there are two examples actually for this. There's one where it's a durable medical equipment, and COVID has accelerated a lot of our work. So within our innovation team, digital is the area that I lead. My colleagues that lead diagnostics have been very keen to find ways to bring about very, very high volume diagnostic tests. Those are both molecular tests, so similar, not exactly real-time PCR, more endpoint PCR, but driving the costs down 1 or 2 orders of magnitude from where they exist right now. The other, of course, is using rapid diagnostic tests, so lateral flow assays, but doing so in a construct that can print the equivalent of the year's supply, meaning like the entire output of the world in 1 month. All right, so again, an order of magnitude increase in the capacity to make these tests. The question for that we face, and this too, I would argue is similar with the genomics, although from Ben's presentation, we already see some of the answers to these questions, is if we had, right now the needs around testing are exquisite, right? We remain in this exigent circumstance. Testing is going to remain a critical piece of the public health response, even as vaccines increase, particularly as vaccines increase, in fact. And yet, I don't think we have seen in many parts of the world that the testing has actually subsided, right? The number of tests done have either plateaued or, in the case, again, of the US, not that we'd want to replicate this, have gone down by 1/3 as vaccines have increased, which is an unfortunate reality because here we may have actually gotten to a point where testing and tracing would have been tractable. So the question is, when you have such a high capacity of these types of tests built in a way that allow for molecular tests to come in at under $5 a test and a lateral flow assay at under $1 in total, into a market that currently is paying many multiples of those, then what do you do with that when you no longer have COVID, right? Are there other infectious diseases or other public health questions that you would want on those same platforms? And so we've already been thinking through the sustainability questions of establishing that these technologies can be built, that there's a tech transfer already in place. So as an example, the lateral flow assay, we're working through how to bring that onto the continent of Africa for manufacture there in very high volumes. And then, of course, there's the use cases, right? So the public health use cases are critical, but like with so many of the things, going back to your question on disruption, this is one of those circumstances where if you build these technologies appropriately, there could be use cases that we have no idea how to use them now. It could be the entire financial flow of ensuring that these have sustainability. The flip of this is the non-durable components, the software part, the thing that I spend a lot of time doing. And in these circumstances, what we have really been trying to do is to take the best of the design and the components that we see people trying to do at the very front end, so the client, if you will, the app or the website, but ensure that right now there has been an unbundling of services that have occurred across the high-income world. So as an example, a telehealth provider in the US, say 5-10 years ago, would have had to build the entire stack on top of something like AWS, but build a billing system, build a EHR system, build the way to do a video conference, have all of this kind of integrated in order to even offer the service. Just as the typical disruption in technologies tend to be like base up, right? And that's exactly what Amazon did when with all the microservices. We saw this same exact pattern occur over the last 3 years in telehealth services. So many of those individual components now suddenly are their own companies, right? And there's a company that you can go to do just the televisit, right? Similar to Zoom. You have companies that are doing the billing. There are companies that help you text message, right? Twilio and others. So with all of that unbundling, now it's a matter of finding a way to rebundle all of those services in a differentiated offering for individuals. I don't think that telehealth is the solution for a lot of what we want within the low resource setting. It's not the complete solution, I should say. I mean, certainly it will play a role, but that's the type of scale that we would want to build, where you have global scale already in the component services, and we are
pull them together.
spending much more time building those building blocks so that we can recompose how the use cases come together.
Okay, I want to switch to an area that both Ben and Pairoj spoke about, which is training. And I want to tie this to the concern raised in earlier sessions around the brain drain. And I know that in an earlier session, one of the panelists said brain drain is a happy problem, right? That some countries have no brains to drain off what to even speak about. But have you guys thought through, and maybe I will start with Pairoj, but how, if Australia offers very generous training positions and so on, how do you make sure that the capabilities really contribute back to the host, really back to the intended country? I mean, like when I did my really public health training in the US many years ago, the funder's specific mandate was that I had to return to Singapore. And I know that in Singapore, we are very big on service obligations. The government pays for one's education, and in turn would then maybe indenture is too strong a word, but would then the scholarship recipient would be beholden legally to serve a number of years. But what are your thoughts around this? Maybe you can start with Pairoj.
Okay, for the area of the capacity building or the
Yes.
workforce training, I think we are in the same way that we have working together. It's a co-benefit among the host country and the recipient country. And we can invest in the short term, but for the long term benefit. In Thailand, we have sent many students abroad for learnings for about the new technology and go back to Thailand. They can be the seed person to catalyze the system, build the system, work more, and at the same time, they can reflect or share the data for the host country, for the other country, and develop more on the knowledge, for stronger knowledge, for widen the community of the expert. So I think that it is a co-benefit of the not only for the Thai, for the host country, but I could say that it's for the mankind. So,
but Pairoj, what if they don't come back? I mean, let's say, and if I can turn to Ben, and let us say that Pairoj sends his most promising juniors to Ben to learn about pathogen genomics, and Ben thinks, wow, these guys are brilliant. They'll be great in my team. What then should Ben do? Ben, over to you.
That would never happen, Jeremy. No. It's a challenge, isn't it? And I think you know, I alluded to the fact that the bioinformatics and the genomic epidemiologists that do this work, there's not a lot out there. And I would say even within Australia, there's been competition to find people in the labs that are rapidly scaling up in this space in Australia, let alone that regional impact. I think there definitely needs to be strategies in place, as you've alluded to. I do think the other way to train is to build networks where, you know, we almost do some on-the-job training. So like the public health labs in the region work together on the program rather than, you know, that's not going to be the only solution, but, you know, rather than students coming to train at the university here in the lab, etc. So we probably need to think about different models of training. You know, we are doing some work with the Fleming Fund in the antimicrobial resistance space, and they do have that model of on-the-job training. So the fellows don't come and spend 2 years in Australia, but they do the fellowship while they're still doing their day job. And I think that's an interesting model. It's challenging because of the time constraints, but it does mean they're working on their data from their job or their institute, and maybe will be more likely to stay in that position and continue to work on that data in a collaborative way with the host institution in another country.
And there's an interesting question that has come in around precision public health moving upstream. And if I tie back to an example that Harvey mentioned around I think the company is called Propeller Health, where it takes, and this is a respiratory disease focus company, where it looks at the environmental data, pollen count, pollutant standards, the really pollutants in the environment, and what should then happen if really precision public health moves upstream, we determine that there are social, there are environmental determinants. What then should we do about it? Maybe if I turn to Andrew first and then Pairoj, because this is a health promotion issue, right? Yeah. And Andrew,
That's
just
it's a great
quick,
question, Jeremy. This one is a really tough thing, but it comes back to the action, the what to do about it is absolutely there's a sovereignty question, but right now I think that we're just completely blind. Right, so we can't have precision public health without data. I think that's been the theme that you've seen across these 3 days.
Yeah.
I think so one of the core elements, of course, is ensure that we have data systems that we trust, that citizens trust, and that from a population standpoint can give appropriate fidelity to some of the phenomena that we do care about. But I am reminded of this exact point, and Propeller is one example of many of these companies that are looking at components within our environments that we may not have the capacity or the will to really make a difference with, right? Many people who, in fact, there was a study that we recently saw in the UK, and it was one of the few examples that I've seen where it was the Population Health Management Corps that was looking at birth weights across children, and then using GIS data, found that children who were born, whose parents lived closer to bus lines, tended to have a reduction in birth weight. So the diesel fumes were the culprit, they hypothesized.
Okay.
And so the intervention was to transform the buses to no longer emit diesel fumes. That is a massive undertaking, but one that the UK could do. And after that intervention, in fact, found that there was a renormalization of birth weights, even for those living near bus lines.
And that's a wonderful example. But if I turn to Pairoj, where perhaps in the Thai setting, it may not be so straightforward to say let's phase out the diesel, the really polluting buses, and move to something else.
It's a good question. How about the good health is? I think that we are determined by the environmental factors, human factors, and also in the lifestyle. And the new one is the commercial determinant that affect our health. So to my sense, I think that we should work in all issues that affect our health. And for my experience in the lifestyle modification, I think the digital and the precision of public health can use. I have just learned from the Singapore that we can use the big data to find to identify some behavioral issue, and we can send the direct message, recommendation, or motivate them at their like an individual level, and they can change the behavior, like a running, like a more physical activities, or identify what the food that they can intake every day. So this is an example that we can use the digital to identify something and use this as a raw material to cook the solution at each level or each at individual level. One more question about, I think that we talk about only the public health, and in the real time we have to deal with a non-health sector or non-public health sector. May I ask for the others to share about this one? Thank you.
No, and thanks. That's a great question around how much should we be involved in the non-health sector. I mean, personally, I would say that the public look at us with utter disdain when we tell them to exercise and to eat well, but they then tell us that healthy food is more expensive, and we say, well, these things are tough, or I don't have a park near me, and we also say, oh, these things are tough, can you walk on the spot in your home, and so on. So it really takes two hands to clap. And how then do we make it easy to do the right thing? And I'm really reminded of the classic really public health really analogy of a person pushing a cylinder upslope, right? Yes, individual effort is important, but society, government's efforts determine the gradient of this slope. And the challenge for us in positions of policy making is that, are we doing enough to lower the gradient of this slope so that people can find it easier to do the right thing? And especially, I would suspect that with more and more data in a precision public health world, we will find that many things are really beyond individual effort. And I would not be surprised, honestly, if governments say, Pairoj, please don't tell me about pollution. I don't want to know. I cannot do anything about it. Any reactions, Ben?
Oh, well, that's exactly right. Thank you. Yes, this is a very focused response to that question. But the public health unit we work with, they don't want to know sometimes necessarily about the extra salmonella outbreaks that we can detect through the genomics, because they don't have the capacity to investigate and respond to all of those. So I think you have to be careful what you present to your public health agencies, depending on what that relationship is, and have them on board with the design of that data stream or whatever you're going to do. Because if you're going to put it on them or make it publicly known that this is a threat, but they don't have the capacity to respond, that's a risk.
Okay, yeah. Andrew, any comments about this?
Yeah, I think that this is, again, I think the data can lead to policy recommendations, but I think that it's a collective action that's going to be the more meaningful component on many of these things that are outside of health.
Yeah.
But I do think that we have to, it's silly to put blinders on, because so many of these other social determinants do affect the rest of the data. And so it should be collected. It's just a matter of how to make a change.
Yeah.
If you
All
see
right.
something.
Thanks. Gents, we have about 10 minutes left. I do want to tackle two last themes. The first is around the role of equity, and we all are mindful that Asia, like the rest of the world, is full of inequities, especially around health. In a world where precision public health is the norm, do we see these inequities worsening or getting better? And what would an optimistic scenario look like and why? What would a pessimistic scenario look like and why? Okay, I will ask Ben, what do you think the optimistic scenario looks like?
The optimistic scenario is that, that we do have some equity in delivery of the technology. And remember, I'm very focused on pathogen genomics, and I'm not thinking it more broadly than that. But infectious diseases are obviously a major public health issue in Asia and the Asia Pacific. There is certainly a risk, but the positive, the positive would be that if we can work collaboratively and work in a way that we share knowledge and learnings that will benefit the region, because infectious diseases don't stick to national borders or internal borders, and we all know that, obviously. But I think there's a collective benefit from deploying this technology broadly. So, for example, as you alluded to earlier, by Australia providing some support in the region, that it may ultimately improve Australia's health position as well. So that's the positive.
Yeah. Maybe as the moderator, let me take the privilege of painting the pessimistic scenario that I fear is the more likely scenario, that in a world awash with data on where to live, where the risk to health are, the rich would gravitate, like I know that billionaires from Silicon Valley are building bunkers in New Zealand. And unfortunately, when there's more and more data that comes out of the good work that precision public health practitioners do, it then reveals the really disparities and the opportunities. And I fear that unless public health professionals, governments are single-minded and very proactive in addressing equity, the natural state is to descend into the pessimistic scenario where the rich have more opportunities. They know where to go. They know the foods to eat that don't have contaminants and really so, and all the factors that collectively contribute to better health. And that to me is a concern. I know the Gates Foundation is very concerned about inequities. Andrew, where do you see the digital health mandate that you have contributing to improving rather than worsening the inequities?
Yeah, I think I share this this view, the pessimistic view that you allude to as the warning bell. We already are seeing the digital divide only increase, right? So whereas we think the digital tools could improve access, could lower barriers, can help those at the very, very bottom in the tiers 1 and 2, living on $1 to $8 a day, say we still do not find that the infrastructure is being put in place fast enough. So while I paint a picture that it's possible to leapfrog and to take advantage of communities, those who are the poorest aren't even on the ladder to increase, right? This is the old story that the subsistence farmer is not even we're not even addressing the issues that they have, and I think that is one of the areas where precision public health must make, as part of its mandate, the ability to collect data from all beneficiaries, right? And we have found many examples where this has been done to great effect, but also where even just the natural order of caste systems in India, or just the fact that the poor may live further away from the center of the village and be not tallied, and so therefore not part of a BedNet campaign, as an example. Those are the types of systemic inequities that we think data, if collected appropriately and utilized for appropriate outreach, can start to address some of this, but it has to be deliberate. This isn't going to be just naturally occurring because we've built the business of the digital tool.
Thank you, Andrew. And I'll switch to Pairoj, because Thailand is really the country of health equity. It's one of the very few countries that provides healthcare to the undocumented workers, and is so-called, in other countries they would be called them illegal immigrants. They would live underground, but Thailand has very generously and graciously really extended healthcare privileges to this population. So can I ask Pairoj, in your country, Thailand, given the natural inclination or the bias towards equity, with more data, more insights coming out from precision public health, how do you see the Thai Ministry of Public Health and other agencies using this to reduce inequities, to improve health equity?
That is a great question. Thank you very much. For Thailand now, we raise the priority of the equality in our national level, and we work in many programs to support to solve this problem, particularly for the healthcare system and educational system. We have specific funding mechanism, and now the government have decided the works that support this issue. I think that is come not from the design itself only, but it is from the common goals. Particularly in Thailand, we have the Akai, so we are looks in a positive way to give the better one to everybody in our nations. So we apply the knowledge that we should give everyone the best start, and then try to solve the problem that they face, particularly in the rural area, for the some vulnerable populations that it may not enough now, but if we can commit to solve this problem. So in the future, we can certainly and trust that we will meet the goal. And I think Thailand, even we face the budget constraint on the healthcare, but the evidence has shown that it comes from the political commitment and common goals, and we can allocate the very limited resource to solve the top priority problem in our country, like a universal health coverage that Thailand we can share the experience to the other countries.
Okay, thank you, Pairoj. And we are down to the line. We have 3 minutes left. I want to end off by asking each of you just very quickly, and the specific question is for budding public health practitioners in Singapore, and I'll extend it to your own countries, whether it's America, Australia, or Thailand. What possible avenues are there to participate in precision public health around the region? Andrew, you want to start?
Sure. Yeah, I think at the moment, I'll speak to the US context. I think Singapore actually has many different opportunities. But Jeremy, you're much more expert to speak about those than I would be. But in general, I would say that the public health workforce has benefited a great deal from those who have come from various backgrounds. And I think just even underlying Ben's talk and a lot of the discussion we've had here, having people with these different skill sets and different lenses applied to public health questions is the key. So we are finding that there's, as an example, a digital workforce that's being generated and starting to build tools to support public health. There are intern programs and additional programs now for even doing contact tracing. So a number of ex-software engineers that I worked with have become expert contact tracers. While this isn't the precision public health that we think of, that sort of introduction in this exigent circumstance, I think, is going to lead to downstream, people will shift and it will be applications led by the fact that we saw this, we lived through this pandemic together. How can we avoid this in the future or do things more efficiently than the existing status quo?
Great. Thanks. Ben, over to you.
I'll just echo those thoughts. I think, there are plenty of programs for public health training in Australia and opportunities to work with regional programs that are funded either by, funding agencies in Australia or WHO relationships or other things. There is a Masters of Applied Epidemiology program that, is now working towards understanding a bit more about the use of genomics in the public health space, and it's very much a practical on-the-job training program. So I think there are opportunities to do those things, but the concept of precision public health, I think through speaking about this more and having more engagement with that concept, that will help bring these programs into that mindset as well.
Yeah. Thanks. And maybe Pairoj, a very specific question for you.
Yes.
If I had if I had public health trainees in Singapore, in our national university, who asked, are there things we can meaningfully do in precision public health with Thailand? If I send them to you, what would you want them to do?
I would like to share the experience with Thai context to them first, and then I will receive from your experience to learn. And I think that now the precision public health is a very popular one, and we have talked a lot. And so this is additional tools for the public health. So we would like to share, to learn, and to summarize the idea together.
Yeah. All right. Thank you. And thank you very much, gentlemen. It's been a wonderful discussion. I would say that the future of precision public health in Asia is very bright. I think the spirit is willing. The flesh is not weak, but it's not as strong as we would want it to be. It can always be stronger, but it's very heartening that there are so many like-minded, passionate people who want to make a difference. And on this note of optimism, I'd like to call this panel discussion to a close. And thank you very much once again, gentlemen, for answering all of these questions. Thank you.